Respected Brit sir, most respected Ekida sir, thank you very much. Thank you very much for this kind introduction and for the nice words of encouragement. Let me also thank my dear friend Dr. Benchit Sabu, Dr. Isar Arvind, and the group for giving me this opportunity at the Diabetes India. So my topic is on a revolution with respect to the meal time management of diabetes. So these are my disclosures. Since we are commemorating 100 years of discovery of insulin, let me start with a little bit of history. And this is 2 a.m. early in the morning on the 31st of October, 1920. And this is the story of Frederick G. Banting, who is one of those innovators of insulin. He was originally a surgeon practicing in London at Ontario, Canada. And he conceived an idea. And that was, remember, 2 a.m. early in the morning. And that was under the influence of a lecture he did the last evening. And this idea was to isolate the internal secretion from the pancreas, which later on led to the isolation, the purification, and ultimately the successful clinical use of a new formulation in science. And over there you see the House of Banting, and that is at Adelaide Street in Canada. And this house is now a National Historic Site and is owned by Diabetes Canada. And that is history. And that is history. And the innovation continues. The innovation continues. The search continues for better and better insulins. We don't stop there. We are trying to find, we are searching for the formulations for better matching with the physiology, for a better insulin before the meal, for a better insulin to be injected as a correction bolus. I will tell you the reason. Last week, I was lecturing to an Indian Medical Association group of doctors. And there was a question. This used to be an often repeated question. Hey, doc, we are treating COVID-19. And in more than 95% of those patients, we are finding extremely difficult or rather impossible to manage glucose. The glucose is remaining above 300 or 350, and that is despite all these insulins and infusions. Do you have any insulin formulation or any new insulin which can bring down the glucose? And we are trying to discuss the answers to all these questions in the next 15 to 20 minutes. And this is the ambulatory glucose profile report, which has become a rule. And now it is part of the American Diabetes Association clinical practice guidelines. All of us are actually supposed to hand over an ambulatory glucose profile report to patients with diabetes. And this looks like this. This is a model report where you have the data from 14 days of glucose monitoring, which will appear as a 24 hours model graph. And then you have a bar diagram over there. And that is going to be the rule. The time in range for those monitoring from the CGM, and probably the points in range for those gathered from a glucose meter, which will provide you in green the time in target and time below target in red and time above target in yellow. So how can you reach your target without a hypoglycemia, avoiding the time above the range and reaching an acceptable time within the range? And that is what we are searching for. Times are changing. Times are changing. Everything is transforming in life. The way we travel, it has transformed over the last 50 years. Our lifestyles have changed over the last 50 years. Probably the only thing which has remained probably will be the sexual habits of the humankind. Look at the ancient Indian diet, which used to be very rich in fiber, with small amounts of digestible carb, and the protein was moderate, the fat was moderate, it was low in sodium. But if you explore into the modern Indian diet, the diet is very rich in carb, low in fiber, and it contributes to insulin resistance, and we are all living longer. The modern medicine has contributed to living longer. We have the statins, we have drugs for hypertension, we have drugs for treating infections such as antibiotics. And there is increase in the overall food consumption, which is low in fiber and rich in refined carbohydrates in particular. And we need to explore, and we need to more and more utilize the tools to help our patients. And this is the example of a tool, and this is the data from a Libre Pro. All of us are performing this, but here the difference is the arrows pointing are the 1 hour after the meal. Exactly 1 hour after the meal, there is a glucose excursion. And this glucose appears to be normal or rather acceptable at 2 hours after the meals. Is it common? My honest answer will be, this is extremely common. If you measure the glucose at 30 minutes after the food, 60 minutes after the food, and 2 hours after the food, for major food items such as chapati, dosha, idli, pongal, upama, and in red you have the 60 minutes, that is 1 hour after the meal, there is a significant glucose spike. And this actually comes down. The glucose is dropping at 2 hours. And this is a gap. I would say that this is a gap when we are treating our patients. And we need to close this gap. We need to close this gap, bringing down or normalizing the glucose spikes at 30 minutes and 1 hour after. Because why is it important? It is important because postprandial glucose excursions are well known. This is a Saint-Louis Gonzalez diabetes. So from all these studies, we now are very well aware of the fact that post-meal glucose excursions invariably result in cardiovascular events. A while ago, in the previous session, we were speaking on cardiovascular outcome trials. So in diabetes, we are all scared of cardiovascular events, and postprandial glucose excursions are a major phenomenon where even 1 hour PPG could be more dangerous than the 2 hour PPG. Why is 1 hour more important than the 2 hour? 1 hour is more important than 2 hour because if you look at the continuous glucose monitoring data, in more than 70% of our patients, 1 hour PPG is significantly more than the 2 hour PPG. And almost all these clinical trials and the experiments were originally performed by none other than Antonio Sciariello. 1 hour PPG, it results in increase in the arterial stiffness, LV mass, LV diastolic dysfunction, and the oscillating glucose values going up and down. And this has been again demonstrated by Sciariello Ariel, and he has demonstrated the oscillating glucose values even in the absence of diabetes with clamp studies in normal glucose tolerance, resulting in significant endothelial dysfunction. And hence, our treatment and our strategies need to be modified. We need to probably utilize the newer modalities and therapies. And this is the only solution to take care of the postprandial glucose excursions, both at 1 hour after the meal and 2 hours after the meal. And this is a real scenario. What is actually happening in the outpatient setting, in the emergency setting, in the inpatient setting? These are the challenges. 2/3 of the respondents in this survey, in the outpatient setting, our patients are forgetting the bolus. They need to bolus a particular time before the meal. They have to calculate, and they are calculating incorrectly the boluses. And they are eating more than the insulin is covering for the meals. And in the inpatient setting, which probably we are all bothered about currently, when millions are getting treated for COVID-19 and for diabetes, inappropriate timing of the regular insulin. The regular insulin need to be injected 30 minutes before the meal. And the illness, the acute illness itself will induce a stress, and this increases the glucose values, especially after the meals. So these are the PKPD limitations of some of the popular insulin, such as the regular insulin, with a very slow absorption, and then it is unpredictable with a fairly long duration of action. The insulin need to be injected 30 to 45 minutes before a meal. So a lot of planning is required before injecting a regular human insulin. Look at the ideal scenario. So the ideal scenario will have the rate of glucose appearance like this, and the rate of glucose disappearance matching with that of glucose appearance. And that is with the right insulin dose, and that goes along with the right injection time. So this is a scenario when there is too little insulin dose or too late dose, when there are chances of either a lasting hyperglycemia or a post-meal hypoglycemia. So we need to avoid all these unnecessary situations and challenging scenarios with the help of a newer insulin. So remember, our quest continues. Our search continues. We haven't stopped at 1920s. From the discovery of insulin, we have been exploring better and better and better solutions until for a mealtime insulin, we have invented the ultra fast acting insulin aspart. And why insulin aspart? The insulin aspart was necessary. Ultra fast acting insulin was necessary, and it was made possible with the result of several experiments. So earlier we were trying with sprinkler needle, inhale insulin for a rapid acting insulin. With other additives we are trying, and injection side we were applying the heat to increase or to hasten the absorption of insulin. We were using other chemicals such as hyaluronidase or treprostinil, which is a prostaglandin analog. Some of these were successful, but with Fiasp, it has been a tremendous, it was a stupendous success to have the most successful fast-acting insulin. So let me compare the popular existing analog insulin, such as Lispro, with human regular insulin. So what has happened with analog insulins? It allows for faster dissociation of hexamers so that the monomers get absorbed into the circulation very rapidly. And with glulysin, when compared to human regular insulin, it provided better physiological postprandial control with a similar mechanism of action. Of course, the only surviving inhaled insulin, that is Afrezza, has a rapid onset of action and a quicker offset of action with a shorter duration of action compared with both human regular and the existing rapid-acting insulins. So what about the popular aspart when compared to human regular insulin? We know with the advent of rapid-acting analog insulins, the monomers are rapidly absorbed into the circulation. But let me compare aspart with Lispro. The popular aspart, the time-tested aspart with Lispro, the postprandial glucoses were more stable with aspart when given as a pre-meal bolus, leading to smaller glucose excursions. And this actually documents aspart far better than probably Lispro as a rapid-acting insulin. So the clinical benefits of aspart are well established. They are well documented. And this is the insulin which is used for the treatment of diabetes in all age groups, starting from 1 year onwards. And this is the insulin of choice in insulin pumps and for intravenous use in the hospitals. And for in-hospital, it reduces the in-hospital mortality. It reduces the cost of hospitalization. And this is the preferred insulin in the presence of pregnancy in elderly because it retains the PKPD property. So we are now searching for a better opportunity. We are searching for a better opportunity to very closely match the first phase of insulin secretion in type 1 diabetes and to replace the early insulin secretion which is lost in type 2 diabetes. Look at this graph, comparing the physiological insulin secretion, which is depicted in blue, compared to the dotted colors over here, and that is ultra fast-acting insulin. So the ultra fast-acting insulin profile is again shifting towards the left when compared to the popular rapid-acting insulins. And it is very closely matching with the physiology thanks to the absorption modifier niacinamide and L-arginine, which is added for the stability of insulin. So whenever we are discussing a new insulin, the question is, why is it and how is it different from the popular insulin? Look at the advancement long ago, and this is in 1990s, when human insulin is compared with insulin aspart, when there is a 38%, 38% greater insulin action in the first 30 minutes after injection. And when we move from insulin aspart to the new faster acting insulin aspart, there is a further improvement. There is a further advancement in the science. And when you compare faster aspart with the conventional insulin aspart, there is again a phenomenal 74% greater insulin action in the first 30 minutes. And this explains everything. Why and how the new faster acting insulin aspart is different from the popular aspart, and how is it different from the conventional human regular insulin. So this is a formulation which is far, far superior to the existing regular and rapid acting insulins. And this has been tested in the onset clinical trial programs, both in type 1 and in type 2 diabetes. In type 1 diabetes, significantly better hemoglobin A1C reduction with faster aspart when compared with conventional aspart. And this is at baseline and this is at week 26. And in type 2 diabetes, equivalent reduction in hemoglobin A1C, and the new insulin has been proven non-inferior with respect to hemoglobin A1C reduction. Remember, whenever we are innovating and exploring solutions, the new insulins are not meant for a potency. The new insulins are meant for more safety and a better duration of action and an improvement in the time in range. And this is again faster acting insulin aspart when compared to insulin aspart, documenting a better PPG reduction both at 1 hour and at 2 hours. Both at 1 hour and at 2 hours. And this is a dream come true. This is a dream come true in both type 1 and in a vast majority of patients with type 2 diabetes, when we have a formulation to bring down the glucose even at 1 hour after the food, and that too with no added challenge of hypoglycemia. This insulin has shown significantly lower risk of hypoglycemia. So when I say significantly lower risk of hypoglycemia, this is with respect to overall hypoglycemia and nocturnal hypoglycemia with fast-acting insulin aspart. And now the question, what about the postprandial or meal-related hypoglycemia? That is again significantly lower. Look at 2 to 4 hours after the meal, and this is time when you are scared. Whether look at regular insulin, it will have a long duration of action of 6 or 8 hours. So in contrast to the earlier insulins, there is no reason and fear for hypoglycemia 2 or 4 hours after the meal. So this is a recent publication from Diabetes India, and I know this is the Diabetes India conference. It is not published online. This is a journal brief proof. And this is a need of the hour, initiated by Dr. S.R. Aravind. And here we are formulating a guideline on how to treat diabetes in the presence of COVID-19 and the corticosteroid use. Let me very briefly go through a real-world evidence with the use of faster aspart. And this is a go-bonus study. And these are subjects already experienced with the use of Libre. And this is how the primary objective and the explorative secondary objective has been designed in this study. All patients with sufficient data for analysis of FGM, and this is the hemoglobin A1C, but I just wanted to emphasize that with the use of faster acting insulin aspart, there was a significant improvement in time in range. Because time in range is a new goal, and that is a new parameter, and that is a new glucose metric for determining the prognosis when we are treating diabetes. So when can we inject faster acting insulin aspart? This is the only insulin currently available in our country, which can be injected either 2 minutes before the meal or 20 minutes within the start of a meal. And already proven to be safe in the presence of pregnancy and diabetes, proven to be safe in children associated with a significantly greater glucose lowering effect in type 1 diabetes, and can be used at all age groups, including in elderly and those with impaired renal and hepatic dysfunction. So these are my broad conclusions. A better insulin for control of glucose at 1 hour and 2 hours with improvement in time and range with a flexible dosing and a significantly lower risk of hypoglycemia. This is my last slide. And this is one of those presentations, an oral presentation at the ATTD last week on our virtual COVID IP care. And in our virtual COVID IP care, we have been intensively managing our patients with diabetes and on corticosteroids with as many as 10 to 12 injections of faster acting insulin aspart daily. And that was across a telemedicine based care. So I thank Diabetes India, and I thank all of you, my dear friends, for your patient hearing and for the opportunity. Thank you very much, Udasa.